Thank you.
Dr.
Thank you so
Rashmin,
much.
please.
Thank you. Thank you, Dr. Mukesh, for very kind and hairy introduction. Uh, so now, after looking at the optic disc edema and pallor, we are going to look at how do you localize the lesion. In neuro-ophthalmology, apart from optic disc problems, you'll also find a problem which is behind the optic disc in the visual pathway and also in the ocular movement. वहाँ पे? RO. The other presentation.
Meanwhile, we can have some
All right.
questions from Rohit.
So
If
let's start with
okay,
this.
he's ready.
What is this visual field effect? This is a binasal hemianopia, correct? Binasal hemianopia. Do you agree this is hemianopia? Because there is a vertical demarcation and there is a field effect which is respecting vertical midline. So do you agree that this is a binasal hemianopia? No. Then what is it? Bitemporal. Why did you say that? Why bitemporal? Why do you say this is temporal? Why not nasal? I know I have given you a clue by writing right and left eye here. If I had not given you that right and left eye indication, would you be able to know what is the right field and what is the left field? Blind spot. And blind spot is generally nasal or temporal? Temporal. And here you are not able to see the blind spot. That's the reason you are saying that this is a bitemporal hemianopia, right? So when you are given the fields, first thing, look for the blind spot. That will tell you the right and the left field. Once you have determined which is the right and left field, if you don't have an indication on the visual field, then always read the field by keeping the right field on your right side and left field on your left side. Please remember, when you're reading any visual field, first thing, determine the right and the left side. Second, make sure you read both fields together. And when you're reading both fields together, right field on your right side and left field on your left side. That's very important. So what you're seeing here is bitemporal hemianopia. Where would you localize the lesion? Where would you localize if there is a bitemporal hemianopia? Optic chiasm, right, absolutely right. So what are the other features of optic chiasmal lesion? Apart from bitemporal hemianopia, what are the other features that you look for? Would you look for anything in the fundus? Fundus, what would you see? If there is a bitemporal hemianopia, which fibers in the fundus would be affected? Nasal fibers. Nasal to what? Nasal to optic disc or nasal to macula? Nasal to macula. All right, when you are talking about the visual field representation, macula is your center. So fibers nasal to macula serve your temporal visual field, and because you have a bitemporal hemianopia, those fibers would be affected. So fibers nasal to macula generally get attached in a horizontal raphe on the optic disc. So what you'll find in the optic disc in the patients with chiasmal compression would be a special type of optic atrophy called bow tie optic atrophy or a band shaped optic atrophy. All right, you find this because the fibers nasal to macula are gone. These fibers generally get attached on the nasal raphe. What do you get on the superior and inferior pole in the optic nerve? What fibers? Arcuate fibers. They are affected first in glaucoma, while in this chiasmal compression the other fibers are affected. So if you find an optic atrophy, you will find a bow tie or a band shaped optic atrophy. So that's one feature. And in nystagmus, in chiasmal compression you will find seesaw nystagmus. So we are looking at other features of chiasmal compression: bow tie optic atrophy, seesaw nystagmus. There are two other phenomena which you should remember. One is hemifield slide phenomena and the other is post-fixational blindness. These are the features of chiasmal compression. Hemifield slide phenomena, because of loss of retinal correspondence, the fovea would become tropia. So that is called hemifield slide phenomena. Post-fixational blindness. You remember, if you have patient like this who cannot see in the temporal visual field, if you concentrate on a finger, anything beyond finger falls on my temporal field. Now if I am not seeing on my temporal fields, then I will not be able to see anything beyond a point of fixation. Right? So that is called post-fixational blindness. So these are the features of chiasmal compression. We are talking about localizing lesion. The first instance is in the visual field where you saw bitemporal heminopia and you localized it to optic chiasm. Let's look at another instance. How would you read this visual field? So one on your right is the right eye, one on your left is a left eye. You can see the blind spot, isn't it? So let's first look at the right eye. What do you find here? There is a complete depression of the right visual field, right? So when you have this kind of visual field defect where there is a complete depression, complete black, generally you will say that the optic nerve of that side is affected. The visual field defects that you will get because of the optic nerve problems can be following. It can be visual field defects that you will see in glaucoma, like nasal step or an arcuate scotoma. It's actually an optic nerve defect. You can find central scotoma or centrocecal scotoma. You can find altitudinal field defect, or you can find generalized reduction of sensitivity, which can just be generalized reduction, or in a severe case a complete dark field like this. So now you know that right side is completely dark, so you know that there is some lesion which is affecting the right visual field, right optic nerve. Now let's come to the left side. What do you find in the left visual field? Left eye visual field, what do you find here? Is it a temporal defect or a nasal defect? You have a blind spot here and there is a predominantly temporal defect, isn't it? And it is sort of respecting a vertical midline here. So that is a superotemporal defect which is respecting a vertical midline. What do you think is this visual field defect? Right optic nerve lesion and the left superotemporal defect which is respecting vertical midline. This is an example of junctional scotoma. There are different types of junctional scotoma. This is a common example where one eye optic nerve is affected and the other eye there is a superotemporal defect. Again, you localize the lesion to optic chiasm. So various visual field defects that you can see when there is an optic chiasmal problem. One is a bitemporal heminopia, the other is this kind of junctional scotoma. Now, what is this visual field defect? Let's now first look at the left eye. Can you see a blind spot here? You can't see a blind spot, right? So this is a temporal side and there is a temporal visual field defect of the left side which is respecting a vertical midline. Agreed? Okay. What is happening here on the right side? What do you think is happening here on the right side? This is again a temporal side, this is a nasal side. So let's for a moment ignore this. If you ignore this, what you have is a temporal visual field defect here and a temporal visual field defect here. So sort of incomplete bitemporal hemianopia. Where would you localize the lesion? Optic chiasm. Now, incomplete bitemporal hemianopia which is starting from inferior visual field. So remember, if a visual field defect, if a temporal hemianopia starts inferiorly, the chiasm is getting compressed from above. If the temporal hemianopia starts here, you know that chiasm is getting compressed from below, right? So now, just by looking at the field, you know that this is bitemporal hemianopia, which is starting from inferior part. So you have a chiasmal compression with a compression coming from above. What about this? If you look at only this defect in isolation, what is this defect? It's an arcuate scotoma, right? It's a nasal, it's starting from the nasal side and it is breaking through. So what you have here is an optic nerve problem. As I said, optic nerve defect can cause arcuate scotoma, nasal step or central scotoma. So you have an optic nerve defect. So in short, if you want to localize just by looking at the field, you know that there is a chiasmal compression which is coming from above, and it is also the compression is going towards the right side, compressing on the optic nerve. So not only that whatever is compressing the optic chiasm, but also compressing the right optic nerve. Okay? And this is an example of the nystagmus that you'll find if you see a patient with chiasmal compression. Alright, video is not playing, but as I said, there you'll find a seesaw nystagmus when one eye goes up and intorts, another eye extorts, and then the cycle repeats like this. Eye goes up and intorts, the other eye extorts, and cycle repeats. So that's called seesaw nystagmus of Maddox. Now, so that's about chiasmal compression. Generally, you can localize the chiasmal lesions by looking at the visual field. Now, let's look at some ocular motility issues. The videos are not playing. All right. What's the first impression? Esotropia, exotropia? Left eso. The patient looking to the left, what do you find? The left eye is not abducting, and the right eye, there is a nystagmus. Agreed? When patient looks to the right, the movements are full. Patient looks to the left, there is no abduction in the left side, and there is a nystagmus of the right side. Anything else? Any other observation? What about the left upper eyelid? Do you see the fullness of the left upper eyelid? Why do you think there is a fullness of the left upper eyelid? What is being demonstrated here now? There is also a weakness of the which nerve? Left facial nerve. You can see there is a mild legophthalmos here of the left side. So you have a left abduction deficit and you have a left facial weakness. Now, if you want to correlate, what was there on the left upper eyelid? There was a fullness. So there was a gold weight implant which was implanted to make sure that the legophthalmos does not remain very severe. Facial nerve supplies orbicularis oculi. If the facial nerve is paralyzed, patient cannot close the eye. So the patient cannot close the eye. It is a direct danger to the corneal health. So gold weight implant was there. So you have a 6th nerve problem with a 7th nerve problem. There are two possibilities. We are localizing the lesion. There are two areas in the brain where 6th nerve and the 7th nerve will go together. One is cerebellopontine angle, CP angle, where 6th and 7th nerve are together. And this patient had a CP angle tumor, and the clue towards that was nystagmus in the other eye. So if you have a patient who has a CP angle tumor, you'll have a 6th and the 7th nerve, with the other eye generally may show a nystagmus, versus this patient. The video is not playing. Can you help me with the video?
AV persons, they can help. Video is not playing.
Alright, so what I actually wanted to show was there are two areas in the brain where 6th and 7th nerve go together. One is CP angle and the other is pons. In a CP angle, you will find nystagmus in the other eye. Abduction deficit, let's say if there is a left cerebellopontine angle problem, the left eye would not abduct, right eye would adduct, may show nystagmus, and there will be 7th nerve problem. Versus pontine lesion, where also you will find 6th and 7th nerve to be affected together. In a pontine lesion, again there will be abduction deficit of the same side. Let's say if patient has a left pontine lesion, patient would not be able to abduct the left eye. He'll also not be able to adduct the right eye. So there will be a gaze palsy. Pons is the region where you have an abducent nerve nucleus. So 6th nerve nucleus with PPRF acts as a gaze center to the same side. So if you have a pontine lesion, you will have a gaze problem to the same side with a 7th nerve palsy. So if you have a patient with an abduction deficit, you carefully look at the other eye. If the other eye also is not adducting, you know that patient probably has a gaze palsy and you are localizing a lesion to pons. Other eye is adducting, but there is a slight nystagmus, maybe you are localizing a lesion to cerebellopontine angle. Alright? Let's see if this video plays. What are the other nerves you look at? if you have a patient with a 6th nerve palsy, we said that we look at the 7th nerve because two areas in the brain, 6th and 7th nerve, go together. What are the other tests that you will perform if you find a patient with a 6th nerve palsy? Anything else? Is vision important? Is optic nerve function important? If so, why? Cavernous sinus. So cavernous sinus, generally the optic nerve would be normal, right? The other nerves would be affected. Optic nerve with a 6th nerve, generally the patient would have an orbital problem. So apart from 7th nerve, you'll also look at the 3rd, 4th and the 5th nerve. 3rd and 4th in the orbit and cavernous sinus, 5th again in the orbit and cavernous sinus. If patient has 3rd, 4th, 5th and the 6th nerve problem, how would you differentiate whether it's an orbital problem or a cavernous sinus problem? Is by looking at the optic nerve. If the optic nerve is affected, the localizing the lesion would be in the orbit. If the optic nerve functions are normal, you know that patient has a problem with the cavernous sinus. So patient with 6th nerve problem, you look at the 5th nerve. Always make sure that you check corneal sensation. 3rd and 4th nerve you would have checked when you are checking the ocular motility. Look at the 7th nerve and then you would come to a conclusion whether other nerves are affected or is it an isolated 6th nerve palsy. What's the importance of checking optic disc in the patients who have a 6th nerve palsy, especially a bilateral 6th nerve palsy? Raised intracranial pressure, absolutely right. So remember, bilateral 6th nerve palsy can be a false localizing sign in somebody who has raised ICP. Why would you have a 6th nerve affected if intracranial pressure is high? Yes, it's not really the long course. A lot of times you will give an answer saying because it has a long course. Please remember, 4th nerve has a much longer course than the 6th nerve from the brain to the eye. But it is because the way 6th nerve travels, especially it travels through the sharp edges of petrous bone, that's where it can get compressed if there is a raised ICP. So 6th nerve palsy can be seen as a false localizing sign, not because of a long, of course it has a long course, but more because the way it comes from the brain and reaches the eye, because it goes through the sharp turns and also has a petrous bone which can press the 6th nerve. So if you see a patient, so this is instance number 2 of localizing lesion, which is abduction limitation. If you see a patient with a 6th nerve palsy, look at the other eye, look at the other nerves, look at the fundus, and also see if it's isolated. Then you localize it to nerve, muscle or neuromuscular junction. Third instance of localizing the lesion. If the video plays. Can you try to play the video there? Yeah. So when you want to localize the lesion, one, you can look at the visual fields. It can be ocular motility problem. If it's a 6th nerve problem, we have said that it can be orbit, it can be cavernous sinus, it can be CP angle, or it can be brainstem. Similarly, the other area where you would like to localize the lesion is nystagmus. What kind of nystagmus is this? Torsional, vertical or horizontal? It's moving like this, so that's torsional, right? Any other points? See, when there is a nystagmus, you'll find that, see what happens now when the patient looks down. What do you think? How the eyes are moving? Vertical or horizontal? Vertical, and it's going like this. So the fast phase is to the down. So that is called down beating nystagmus. So what you saw was an example of a torsional nystagmus, where the nystagmus started before the end of the gaze. That is called gaze-evoked nystagmus. Nystagmus which is not present in primary gaze, but is brought about when the patient looks to the right and left. There are two possibilities. One is end point nystagmus, and second is gaze-evoked nystagmus. Here you see the nystagmus comes before the end of the gaze. You can see the sclera of the abducting eye, but you can see the nystagmus. Here you can see the sclera of the adducting eye, but the nystagmus is already present. In an end gaze nystagmus, it comes about right at the end of the gaze, and generally it is transient, versus this where it comes before the end of the gaze. and you find here that it has become vertical, downbeating nystagmus. So if you are asked about localizing a lesion in a case of nystagmus, and if you say cerebellum or brainstem, most of the instances you'll be right. This patient had Arnold-Chiari malformation, and the nystagmus was localized to cerebellum. Can you play the next video, please? So this is my last case. So as I said, when you see a patient with nystagmus, you generally localize it to the brainstem or a cerebellum. Yeah, you can play that video. So what about this? This is a patient who is from down south, interior of Tamil Nadu. What kind of nystagmus is this? The eyes are moving like this. Pendular nystagmus. Where would you localize the lesion? Yeah, you said cerebellum. This is one instance where you will not localize it to cerebellum. I said this patient is from down southern part of Tamil Nadu. So generally you don't find the skin color there. Right? Patient has albinism. So here you look at the fundus very carefully. Albinism is associated with optic nerve hyperplasia or macular hyperplasia. So anybody who has a long-standing fundal defect would produce pendular nystagmus where there is no fast phase. It moves like pendulum. Only one instance where a pendular nystagmus can be a sign of a neurological problem, and if you want to rule that out, you have to look at the palate. Oculopalatal tremor, where there is a lesion in the brainstem, can produce pendular nystagmus with a tremor in the palate. Right? So with that, I think my time is up. I thank All India Ophthalmology Society for giving me this opportunity and thank the chairpersons. Thank you so much.